I'd like to invite Dr. Shaini Kaki to moderate the session on how to use the media to address equity in health and healthcare access by Dr. Parth Sharma.
Good morning, everyone. It's my great pleasure to introduce Dr. Parth Sharma. He's a UG alumnus of CMC Vellore and is currently pursuing his MD in Community Medicine in Maulana Azad Medical College. He's the founder and chief editor of Narana, Public Health Information and Advocacy Platform. He's also a regional leader for the International Working Group for Health System Strengthening for the Southeast Asia region. Apart from his academic publication, he has also authored and co-authored several public health related op-eds in national and international media platforms. Over to you, Dr. Parth.
Thank you for that lovely introduction. Thank you to Anand sir for organizing this. I wouldn't call it a conference, I'll call it a public health concert. The speakers here, and every day I listen to them, I realize how undeserving I am to be here. Thank you for that, sir. As of now, my experience in public health is inversely proportional to my height. So I'll take some time to speak as well as all of you here. And I acknowledge the fact that I'm probably not the best person to speak on this topic. I've been asked to speak on how to use media to address equity and health in healthcare. And before I start, while I was making this presentation, there's one question which came to my mind, which is, where do most Indians live? What does India look like? And this has been a topic of debate even in our media, where people are saying we are underestimating our progress over the years. 75 years after independence, India looks much better. And if we look at superficially, if we look at what India looks like, this is some research that we have done available, whatever data is available with us so far. Even now, 66 to 70% of our India is still rural. So the next question which came to my mind was, who represents India? So if India is majority people are rural, then who's representing us? So I go back to Twitter, and there's the tweet which I found which says that I've studied and worked in the UK, but now I'm back in India and I'm loving it here. I'm proud of the entire healthcare system of our nation. India is the best. Another person who said that paid $300, queued for 2 hours to get an RT-PCR in Palo Alto before flight to India. Here I got it for $7. Didn't have to wait in line. Somebody came home and got the report in 12 hours. So are these people who represent India? Or is it this person? This is a 50-year-old male who has advanced stage oral cancer. The day I met him, he had not eaten well for a week. Severe pain, not much money. The wife sitting behind was crying when I met them. They have a debt of 3 lakh rupees. The son is the only earning member, 15,000 rupees per month. They have a monthly rent of 7,000 rupees. They haven't paid rent for 3 months. They have not been able to. And the landlord is saying they'll have to vacate soon. So is this person who represents India, or is it this family that lives right outside where I stay at the crossing? And I'm sure they have not been in contact with our healthcare system yet. So one thing we know for sure, and over the past 2 days, we have realized that there's an imbalance which exists, which is glaring at us. And if we ask ourselves where we are on this balance, we're surely here. If we are listening to this offline or online, there's a high chance that we haven't personally experienced inequity. So we're not weighed down by the inequity, and we are definitely on the better end of this. So one thing to acknowledge and to realize is that we have won the lottery of life. All of us are extremely privileged and we have won the lottery. And so the next question that we ask ourselves is, what can we as individuals do to address this inequity? And the most obvious answer, which I'm sure all of you will agree with, is serve those in need. And this is what forms the core of training at Vellore as well. Not to be served, but to serve. But in words of Dr. Ravi Kannan, to get an opportunity to serve is a gift, but to be able to be served is a privilege. And not all of us are privileged enough to serve. There are various barriers, family, time, multiple other commitments. So not all of us can go there out in the community, and we often feel helpless. What can we do as individuals to address this inequity? So there are multiple other ways that I'm going to talk about in detail with examples. One of them is research. And I'm sure a lot of us in our clinics look at patients and we try to think, why did somebody get this disease? Why should that person get the disease? Do we look at patterns in our clinics, in our work? So the first point is to ask, why should somebody get a disease? And then try to answer that question with research, identify gaps at individual level, policy level. generate new evidence, discover new, better solutions. Use that research for advocacy. Be the voice for the people who don't have a voice, whose voices have been suppressed, who are powerless. Spread awareness, which is very important. There's a scheme in Delhi called DAK, Delhi Arogya Kosh, where you can get investigation done, CT scan, ultrasound in a private health center for free. A survey was done which showed that 93% of the people are not aware of the scheme. So if people don't know what services exist, if they don't ask for it, the inequity will not be addressed. So make people aware of what their rights are. We work with an organization called Mahila Housing Trust, and we are working with construction site workers. Just telling the construction site workers that it's their right to have a mask change things, because people started asking for masks from their employers, and we could help them that way. So it's very important to tell people what their rights are, what is good and bad practices in health. And I'm sure all of us will agree it's time to pass the mic. Just doctors talking about health inequity is not enough. People who are facing it should be the ones on the stage having the podium and talking about inequity themselves. And if we are not able to do that, we then should be the voice of those people if they are not able to do that. And lastly, move on to activism. Take vigorous actions to bring a change if nothing else is working. And I feel media forms a common link in all these approaches, except the one where we directly go and serve, and that also is possible through telemedicine. But in other ones, media forms a very strong link to address these issues. And when I talk about media, we often think media is very inaccessible. We think we don't have access to that media. It's something for journalists, something for people who are trained in communication, but it's not like that. Blogs, social media. We often disconnect social media from real world. We think, the popular belief is that things which happen on ground are more important. Social media is something, which is very disconnected. But in today's world, social media is extremely powerful, and the way it's being used right now, it's in a huge negative impact it's having on us. And we know that US elections were affected by social media. Social media has a huge impact. So we have to realize that it's equally important to have a presence on social media and not just think that on ground work is what is sufficient. Newspaper, podcasts, radio. This is not an exhaustive list. There are some ways of how you can communicate with people. Books. So how does media play a role in research? So as I mentioned, as clinicians, we do see patterns in our OPDs of we see patterns of inequity. I'm sure all of us have met patients who have sold their land to seek care. We have met patients who were dharma'd because they didn't have enough money to pay the bill. So research should be people-centric, not publication-centric. Again, address the problems of the people that are facing that inequity and then address those gaps. But is it enough? Is it enough to just do research? As researchers, we feel that our job is to generate evidence, and things stop there. Somebody yesterday only mentioned, we have published the paper, we haven't seen a change. So even we feel that, paper is out, excellent evidence is out, why are things not changing? So one thing is to obviously use media to share knowledge, to disseminate that information that you have. The other thing is social media helps, which I personally experienced, helps to find collaborators to do the same research. You might feel alone. You might feel, I've seen this problem, I don't know how to go about it, and I feel very alone in this world. I can't do this research alone. And if you talk about your areas of interest on social media, you find collaborators. Dr. S.P. Kalantri mentioned Ashish Kulkarni and Murali Neelkantan's op-ed on drug procurement inequity in that. We were just tweeting about it, retweeting each other's tweet, and we sent each other a message saying, we want to work on inequity in diabetes care in India. There is PMJ, there is CGI, there is ESIC, there are state lists. Everybody is procuring drugs at a different rate. Can we do something to identify, if there's one list, how much money the country will save? We just started talking about it on Twitter, and now we're doing a research project. Dr. Nehal is also a part of it. So social media is a great tool to find people with same interests and then collaborate to do research. And then media is obviously one of the easiest and the best ways to disseminate that information once you have generated it. And then once you have generated that evidence, once your advocacy is backed by research, the advocacy is better. And I'll talk about it how. So I'm sure we all know Dr. Anurag and Dr. Madhavi, the famous ration trial which has come out. Now imagine if this trial was not published in a very high impact journal, highly visible journal, this evidence would have been missed completely, that food is the new vaccine. But what I want to stress on here is the amount of effort they are putting into disseminate this information. They are everywhere. They are doing webinars, they are traveling to each place, they are writing articles, they're just trying to disseminate this information as much as possible, which I feel is the most important part of research. The research doesn't end at evidence generation, but it should be followed by disseminating that information, and media is extremely important in that. And how could you do that? Something as simple as a tweet. People are there who with followers of lakhs and lakhs of people, and if Dr. Gagandeep Kang retweets your tweet, it'll be seen by at least 90,000 people. So simple things like that. Tag somebody who's working in that domain, has a lot of followers, and they will also be interested in disseminating your information. Association for Socially Applicable Research. ASR is an organization that I also volunteer with, and we are working on various research projects to identify gaps in our public health space. So one project that was done at the organization was to look at PMJ. So PMJ was brought in to address inequity, but evidence that we generated found that males are more likely to seek care. SC, ST people from those communities have low service utilization. Most hospitals are private. So it's not really addressing the inequity. So we found this evidence, and now we are advocating that things need to change based on this evidence. Otherwise, if we just go and say PMJ is not helping without any proof of it, it doesn't really help, which is why research comes into play when we are advocating using media. I am specifically interested in palliative care, preventive oncology, and at ASR, we are doing a project to look at access to palliative care in India. Now, if I just write an article saying palliative care needs to improve in India, we all know it needs to improve, but where does it need to improve? So we have done this project where we can tell you how long it takes for a person to reach the nearest palliative care center, what percentage of population has access to the nearest palliative care center within 30 minutes if they have a motor vehicle. We can tell you that data, and the area that you see in red, if you're living in that area, you will take more than 2 hours to reach your nearest palliative care center. So if you are in pain, if you're suffering, to even receive morphine, you will take more than 2 hours, and you have to travel by a motor vehicle to get there. So access is extremely poor. And now if we advocate based on this evidence that, and we see a blue patch at the bottom, that is Kerala. 99% of the population in Kerala can reach the nearest palliative care center within 15 minutes. So something is happening well in the country. Something is going wrong in the Bimaru states. What is happening there that we can advocate and use that evidence to advocate in other parts. So again, the evidence generation through research becomes very important. Coming to media and advocacy, I feel storytelling forms a very important part of advocacy. And when we do research, these stories are lost behind the numbers. Everything becomes a number. So the suffering, the stories, the pain behind those numbers is lost. And it's extremely important to bring those numbers out. Because ultimately, when you tell somebody, if I tell you 99 or 96% of the population doesn't have access to pain relief in the country, that doesn't ring a bell as much as it should. But if I tell you the story of a person who hasn't eaten food for 7 days because his jaw is hurting so much because of pain, he has lost 10 kg weight in 2 weeks, and the doctor has told him get high protein diet, but the problem is pain because they don't have access to pain. So if I tell you these stories and then give you the numbers, the impact improves. So, which is why, again, if we start sharing those stories on media of the numbers that we generate, I'm sure all of you have stories of people that finally got converted to simple numbers. So those stories also need to come out along with your research. And again, media is where those stories can actually come out. One example of that, P. Sainath, I'm sure everybody knows him, a very renowned journalist. He founded People's Archive of Rural India, which is just a human library of stories. They published this article called In Jaisalmer, Gone with the Windmills, which was about the land being falsely categorized as wasteland, and then it was being encroached by renewable sources of energy, the companies that build windmills and solar panels, and they were encroaching these lands and they were losing livelihoods. So they published this article, and I'm just trying to highlight what role storytelling plays in this. So what happened was people started protesting after reading this, and it brought together around thousands of protesters. They went to the administrative's office, protested outside that, and they told them that, ये story हमने CM तक पहुंचा दी. We have made the story reach the CM. And later they called and messaged. This is from their Instagram. They have shared the success of their storytelling, and they said they called and messaged to thank us for the story. And they said, this has happened because of you. We prevented this encroachment because of your storytelling. Maladies of the have-nots. I'm sure a lot of you have heard of this. I can see some of you ducking down behind chairs when you read this slide. This is a book that a lot of us are working on, which is trying to answer one simple question. Again, why do people get diseases? Why should somebody get a disease? Why am I not getting the disease, but the other person getting the disease? And I'm sure a lot of you recognize this lady in the picture. This is if you're doing public health, and if you don't know this lady, that means you're not doing public health. This is Vasu. Vasu is sitting somewhere behind. And again, I would just like to request everybody to just clap for Vasu. The amount of work she goes around, the amount of work she does, and it's phenomenal. She is a great source of inspiration for me. So thank you, Vasu. So this is a project that is being led by Vasu. So you're writing a book where if you're getting emails, irritating, annoying emails, I am one of them who's sending that email. So this book should be out soon, hopefully. The next place where we should use media is to raise awareness, and we have seen in the COVID pandemic that the internet is flooded with misinformation, and that is causing more harm than you can possibly imagine. And so now there are two sets of people: either you are completely unaware, or what you know is completely wrong. And thanks to all the false information on internet and social media. But the good thing is that this internet connectivity has brought people closer than they were before. So it's equally easy to address this misinformation if you take the effort. And I'm sure some of you would have heard of this person, Dr. Cyriac Philip, famously known as a liver doctor. So he's single-handedly taken the fight against pseudoscience, misinformation on social media. And he has received death threats, court cases, everything possible that you can imagine. But again, as doctors, I feel our responsibility doesn't just end at writing that prescription. It goes beyond to educating people, addressing myths, misinformation, and finally telling them what is the right practice. Lastly, media and activism. Now, there's this new thing of digital activism where you can start petitions online. Change.org is one website that you can use. And at USSR, we have started this petition. We generated evidence, and we started a petition where we are asking for a new central law to protect healthcare workers against violence. And so far, we have received around 5,500 signatures, and we are pushing the policymakers using this, that, so many people want this, why don't you bring out a policy? So again, digital activism is something which is now taking shape and coming up in a big form. And you can file right to information online. I'm sure all of you know that. Coming to Nirvana, and I'm sure some of you who have been following our work would have just realized it's not Nirvana, it's Nivarana. Because people have come to me and told me, we've been following Nirvana's work, and I'm like, it's not Nirvana. So what is Nivarana? So Nivarana actually means addressing distress, reducing distress. It comes from a Sanskrit word. And in Buddhism, it means it's a set of barriers that you need to get past to attain Nirvana. And one of those barriers is barriers of lack of knowledge, misinformation. So it's a public health advocacy information platform that was founded last year in July. And what we aim to do is address the barriers of ignorance through evidence-backed, easy to understand articles that are connected with real stories of people. We have 6 main work streams. We have our main way of communication is, as of now, is articles. So we write easy to understand, attractive articles which connect with important public health problems. And these articles can be read in 10 languages. We are trying to make our information as accessible as possible. So in 10 languages, Hindi, Kannada, and English, the translation is quite accurate. Other languages, you will get the idea, you'll get the gist of it, but it's not very accurate, and we are working on improving that. So this is our main way of communication. So far, we have reached around 80 plus countries globally in the past 1 year. We have recently started a podcast where we have been doing podcasts in 2 languages, Hindi and Tamil. So again, our aim is in 5 minutes, we have to convey one message. Our first podcast in Tamil was on why should you tell diagnosis to somebody who has cancer? Should you tell it? Is it important to tell them? Another podcast we did in Hindi was, if you are a hypertensive, why should you not take salt? Why does a doctor tell you not to take salt? Simple information within 5 minutes we want to convey to somebody who is not that literate. We do awareness sessions online on Zoom platform where we collaborate with a lot of organizations working in rural India, and we connect with them and we tell them, you bring us the people and we'll give you the information. So we've been able to connect with people in rural Jharkhand, rural Madhya Pradesh, Orissa, Gujarat, Uttar Pradesh. And so they sit in one classroom. There'll be 20 people in a classroom. We'll be on the laptop talking through Zoom. And the first one on the right that you see is during the conjunctivitis outbreak. Again, Vasu and I did a session on how to prevent conjunctivitis. How do you protect yourself? So we did that session. On the bottom left, you see a session on endometriosis that we did again with the rural community, where women were having a lot of menstrual pain, but they didn't know what to do about it, and doctors were dismissing it. So again, we were able to reach out to around 80 to 100 women in rural areas. And Dr. Lily from CMC was our expert here. And I'm really grateful to CMC again, because a lot of people from here have helped me spread awareness. Dr. Gina is here. She helped us in heat stroke. When heat stroke was at peak, we were doing a session on heat stroke, spreading awareness on that. Dr. Joy Maman helped in blood donation, helped us spread awareness on that. And I've been bugging a lot of people from CMC to come and help me on this platform, and they have been very, very supportive. We also do something called forum discussions, public health forums, where we get public health professionals together to discuss a problem. So we discuss problem and we then discuss solutions. This is something happening in your part which you think could solve this issue. So on the top right, again, we did a forum discussion on disaster management in India. And Dr. Priyadash, who is here, he was a part of it. Dr. P.V. Ramesh, who is an alumni of CMC. Again, Dr. Gina, Dr. Sonali. And there were a lot of speakers from different parts of the country who were pitching in and discussing how can we address disaster management in India. Bottom left is a session we did on privatization of healthcare in India. And Dr. Sunil Chandy was there. And we discussed, how can we tackle as medical professionals, public health professionals, how to go about this privatization. Is it good? Is it bad? What's happening in other parts of the country? So what is our ultimate dream at Narana? Our dream is to have a society that is aware of the importance of public health. A society that is aware of the inequity that is faced by the majority. And ultimately a society that is aware of its health-related rights, demands for it, from people in power, not just for themselves, but also for those who can't speak for themselves. And that is our ultimate vision and our dream. This is our team. Christian is who spoke yesterday. Royson, who's also from CMC. Radhika is from Lady Hardin in Delhi. Janvi is one of my students at MAMC. She's a third-year medical student, and Divya is also here today. And bottom is our advisors, the advisory group at Nirvana, Dr. Sunil Chandy, Dr. Gagandeep, my teachers, and Dr. Purnima Menon, who's a nutrition scientist from Delhi, Dr. Sirya Kabi, who's known as a liver doctor, Pranam Chatterjee is a clinical epidemiologist at Hopkins, Pathralika Chatterjee is a journalist, and Siddesh is a researcher. But there are some limitations associated with this use of media. And the biggest one is that anyone can disguise as an expert and confuse common people. So an economist advice to the advisory council of Prime Minister can tell you that lower hemoglobin count cutoff. There is a lot of nutrition misinformation online everywhere. Turmeric helps in curing cancer, and a lot of such information. So this is a problem that anybody with a huge following can give you some information, and you tend to believe it just because they have a huge following. And the other one is there's a lot of backlash if you say something which is not mainstream. And this was noticed during Right to Health in Rajasthan, where a lot of us were saying something that, this is right. And you're facing a lot of hatred, again, threats, everything we were getting messages on Twitter. So when you share harsh realities, uncomfortable truth, you get a lot of hatred. And this comes with, it is like a part of the job. To summarize, the minority is largely unaware of inequity faced by the majority. And media is a way of taking these stories closer to them. So even if 30% of our people live in urban areas, and assuming only 10% of them have access to phone, internet, website, whatever, even if we can make those 10% aware of what's happening in the country, they have the voice, they have the power to influence a change. And so let's take those stories there. And this is what we are trying to do. And media is not as inaccessible as it might seem. It might just be a tweet. It might be your own blog. It might be posting on Nivarna. It might be a newspaper article. It's not as inaccessible as you think it might be. And if you still feel you're not able to use media yourself, if you feel you're not that tech savvy, and you feel any other barrier, you can reach out to anybody else who's using it well. And that's the main reason why Narana has been founded, to provide a platform where people can freely talk about issues that generally the spicy media outlets wouldn't not like to talk about, and that's why the whole purpose of Narana. And there is a dire need of sane voices, especially on social media. So if we stay away from social media and we think our work on ground is solving the issue, I don't think that is the whole picture. We have to be on social media to address all the misinformation, all the hatred that is there on social media, and to promote healthy discussions on issues. And lastly, this is something I tell all the people that I now teach, is that the country does not need just doctors anymore. And the current political scenario, we need doctors, we need health advocates, and we need activists. So what can CMC Vellore, institutes like CMC Vellore, do to address this inequity? How can institutes contribute to addressing inequity using media? So I am from the batch of 2014. I was in Vellore for 8 years. One thing that CMC does wonderfully well is it keeps you close to suffering. It keeps you connected with the people. And the whole idea of serving, it drills it in your brain. But one thing which was missing, I felt, in my training was to teach me how to become an advocate, public health advocate, how to become a public health activist. That is something which I had to figure out later on my own. So I feel that that's something that could become a part of the training here, because a lot of things are happening, which is excellent. But something more which could be how to train people to become public health advocates, how to become activists. The other issue that I have is, whenever I go in Delhi, a lot of policy meetings happen, and I make sure that I go there and I bug people with questions. And a lot of the times I've heard them ask questions which CMC has solutions to. And when I tell them that, CMC is already doing this, the one thing which commonly comes out is, but CMC is a unique institute. There can't be another CMC in India. CMC, and in one of the forums, Dr. Sunil Chandy himself said that CMC has gone through the test of fire for 100 years. It's difficult to replicate CMC. And I have just one question: why not? Why can't there be another CMC? What is, even if we start now here today and say it'll take 100 years, but why not? Why not be replicable? Why not have your, so I'm just a question for you to wonder, is there anything in CMC that has addressed inequity which other people outside don't know about? And if there's something like that, it has to be documented and shared. So CMC has to become more and more replicable, I feel. And that doesn't mean lower the quality. Maintain the quality, but become easier to be replicated in other parts of the country. And ultimately, when we do all this, the question that still bothers me is, can we change the world? Can we ultimately abolish inequity with everything that we have heard over the past 3 days? If we use media, we serve on the field, everything we do, can we abolish inequity? And this is the question that I went to Dr. Johnny Uman with. And what he said was, suffering was there before we came. Suffering will continue to exist after we are gone. Our calling is not to change the world. Our calling is to share the pain. And this is something which has really changed my perspective and changed the way I look at things. So I would like to end by one of my favorite movie quotes from Lord of the Rings, where Samwise Gamgee is talking to Frodo, and he says, it's like the great stories, Mr. Frodo, the ones that really mattered, full of darkness and danger they were. And sometimes you didn't want to know the end, because how could the end be happy? How could the world go back to the way it was when so much bad has happened? But in the end, it's only a passing thing, the shadow. Even darkness must pass. A new day will come when the sun shines, and it'll shine out clearer. I know now folks in the stories had a lot of chances of turning back, only they didn't. They kept going because they were holding on to something, that there's some good in this world, Mr. Frodo, and it's worth fighting for. Thank you once again for this wonderful opportunity.
Thank you, Dr. Parth, for that enlightening talk. We have a couple of questions from the audience. In the face of rampant misinformation across our media platforms, how can we spread the right kind of information to make sure it gets across?
So I feel firstly, we have to establish credibility. Now, there is a video on WhatsApp going around by a cardiologist from Kanpur who says, if you are a hypertensive, you should take salt, because if you have less salt in the body, you will go into coma and you'll die. So what we did at Narana was we made a podcast recording and we put Dr. Sunil Chandy's voice in it. And you're like, this is a cardiologist from CMC Vellore telling you that this is wrong and this is the right thing. So again, you have to and we use the same channel to whatever that forward came from. I send that people the same recording, the link, send it back from where it came from. So first thing is to generate credibility, and that obviously you have to build a brand, and you have to bring the brand value, work hard for it. It'll take some time, but once you generate that credibility, people will listen to you.
Thank you. Another question, does it depend on the media to bring about change or on the temperament of the political leader, or both? Are there any other intervention methods?
So I again believe both. So at ASER, what we did, we write a lot about mental health issues, and we reached out to state of Maharashtra, and we had a person there, and we told them, we'll generate a PDF, PowerPoint presentation for you. Why don't you present this to the policymakers? So again, use of media. And we did that. The policymakers agreed for a policy change. And now ASER is working with Maharashtra state government for a state mental health policy. So I think it's a combination of everything. You have to use media, because the more and more people read about it, they will be aware that these are the problems in the country. And there's a Kingdom's 3-stream model for bringing a change. And the one part of the model is need generation. So unless and until people feel there's a need, there won't be a demand for change. So I guess the first step is to talk as much about the right things on social media, and then keep engaging with policymakers and demand for a change.
I have one last question, if you don't mind. Talking about the role of the media in the research policy nexus, how can the media ensure the legitimacy of a research? Do they critically appraise the research before they disseminate and publish it?
So I believe journalists and public health researchers should be best friends. And Dr. Madhukar Pai, who is again an alumnus from CMC, what he did was he started courses for journalists, how to read research, how to interpret research. And he has teachepi.org is his website, and he has free courses for journalists to access on how to interpret research. So there are a lot of journalists who are trained in that. Those who are not, we have to be accessible to them. A lot of journalists message me saying, this is the evidence, how can we interpret? Do you know any more sources of data that we can use? And you have to be open to sharing all that with them, and not demand that, my name should also come in your article now that I've given you a data source. It shouldn't be like that. So you should help each other. So when I do something and I have some evidence, I send it to a journalist saying, would you like to cover it? And I'll write things for you and give it to you. You just cover it. And that's how I think things should go about it.
If we have time, there's one question from our online group. I have seen the videos and content that generally goes around in trendy media are full of funny anecdotes and memes. Can we, in healthcare settings, spread out some good message in a more fun way to reach out to the adolescents and youth?
So even I had that thought in mind, and we started a category called Common Sense on Narana, where it's just a sarcastic article. We are trying to agree to that extent that at the end of the article, you will know that what we are saying is extremely sarcastic, and you can check. And because we felt like we are trying different modes of communication. So if direct boring evidence doesn't work, I realized that in the beginning I was writing very evidence-based articles, and it was not reaching out to people. So then I started writing stories along with them. And I realized reach improved when there was a very emotional story in the beginning, which was true. And that we increased the reach. Then I tried sarcasm, and then it improved slightly. So I think it's just trying to wrap it well and then give the right information. That plays a key role.
If there are no more questions, we could conclude. Thank you, Dr. Parth Sharma. Let's give him a round of applause.
I'd like to ask Dr. Shaini to present the memento to Parth.